monochorionic twins. Monochorionic twins itself is a big topic. I'm going to just give you certain practical tips and certain tips for the postgraduates. So here I go. I'm going to discuss this topic on as what are monochorionic twins, why are they different, how to follow them, how to screen them, about the screening for downs, how to investigate, triage for complications, how to identify complication, treatment opportunities, when to deliver them, and what are the outcomes. So as we all know that monochorionic twins develop from a single zygote. They got a single placenta with an interconnecting membrane, which is very thin, which is just 2 layers. But what we should keep in mind is that they are genetically identical, but heterokaryotype may occur. This point is important in the sense of genetically transmitted disease. They can be discordant for structural anomalies also. So this is the T sign by which we recognize a monochorionic placenta. Now we know when the blastocyst divides at 4 to 8 days, you can have an MCDA twin. But when it cleaves at 8 to 13 days, we can have an MCMA twin. What is more important is the chorionicity, which should be determined at 11 to 14 weeks. That's because at 11 to 14 weeks, you find that 99 to 100% accuracy is there. If you do it before 10 weeks, it will maybe just 98%. Beyond 14 weeks, it may be 77%. And in third trimester, it may be as low as 60%. And how do we do it? We find that there's no lambda sign, which is a sign of a dichorionic pregnancy, where the placental tissue grows in between the membrane. Whereas here you have a T sign, and you always supposed to do it at 11 to 14 weeks by a TAS or TVS. But if you have missed it, when in doubt, always treat that pregnancy as a monochorionic. That is what the NICE guidelines say. Now, why are these twins different? They are different because although they are genetically identical, they can inherit disorders which can affect both of them. There is placental vascular angiostructure which facilitates inter-twin blood exchange. Their etiology for both discordancy is different. They have high risk of complications. Some complications are unique to monochorionic twins only. They need closer surveillance and they are delivered earlier than a dichorionic twin. So when we look at the placenta, we find that the placental cotyledons, cord insertion, vascular pattern, vascular anastomosis, they all vary in different type and number and direction. You can have an AV shunt or you can have a VA shunt. So when you look at this placenta, you see the yellow color is the artery and the green color is the vein. You find that there is AV anastomosis, there is VA anastomosis. And here you find it in a diffuse pattern. Here you find it in a magistral pattern at some places. So this may vary in various pregnancies. And unless we are able to find out this problem, we cannot help them out. So there are 3 equators when you look at the placenta. One is at the level of dividing membrane. And then there are 2 vascular equators. One is superficial, one is deep. So when we look at the outcomes, what we find that the miscarriage rate is around 75%. The preterm delivery rate is also more than 50%. The IUGR rate is again more than 50%. The fetal defects are more than 80%. All these problems do happen in monochorionic twins. So what do? We have to start looking at these fetuses as early as 16 weeks. And we have to look at them every 2 weeks. And what do you look? You look for the LICA, you look for the growth, you look for the placenta and cord insertion. This cord insertion aspect is very important, which I'm going to discuss over subsequent slide. And you have to look at the Dopplers as early as 16 weeks, the umbilical artery and the DP. And at 18 weeks, apart from looking at all these things, you've got to start looking at the MCA Dopplers. Because if you want to find out anemia, fetal anemia can be detected by MCA Dopplers. And you've got to do a targeted scan and fetal echo. So fetal echo is important to find out the myocardial performance index, which I'm going to talk to you later. And every 2 weeks, we have to find out what findings are evolving because the findings may evolve at any point of time. Then we should know about the appearing twin, which is more common in monochorionic twins. If you scan a patient prior to 6 weeks, there's 80% chance that you may miss a monochorionic twin. And if you scan at 11 weeks also, there is chance for undercounting. So we have to be very careful. 11 to 14 weeks, definitely we should be able to pick up. And there is chance for an appearing twin. Similarly about vanishing twin. Now ART pregnancies are more common, and we may find that in 38% the fetuses may vanish, and in spontaneous it is only 7%. So you cannot assure of ART that you are going to carry on twins. So there is an incidence of vanishing twin, and it will also affect the biochemical markers screening also. And this particular condition has no long-term complications which we are aware of. Another thing is labeling twins. Whenever we see twins, 85% they'll be either on the right or on the left. But 15% they can be cephaloid or caudal. So this labeling is important because we want to follow up these fetuses separately. If we want to do a CVS or an amnio, and if we want to do some invasive testing, but we have to remember there's something known as perinatal switch. Although the A fetus may not deliver first, so that may be seen even during labor, this perinatal switch. Then dating pregnancy. If we are dealing with IVF pregnancy, we use the embryo transfer date. But for natural conception, we should use CRL of a larger twin. Now regarding screening, we find that monochorionic twins have higher incidence of increased NT. And why it happens? It is because of the vascular and the fluid imbalance. They are not at high risk of trisomy 21. Any discrepancy, we should concentrate more on cardiac and other defects. So here you see a twin with NT 4.5, you have 2 mm. So in such cases, what we need to do is use an average NT for calculation. Because discordant NT is more common, it is highest in the monochorionic twins. Looking at the other screening markers, if you see age and NT, it is only 75 detection rate. Age NT combined screening for monochorionic is only 87 detection rate. So the take-home point in this slide is that the monochorionic pregnancy, there's a single probability for the whole pregnancy with an average NT. But if you're looking at a dichorionic, it is a fetus-specific probability. Now, other markers like nasal bone, there's no difference between MC, BC. If DV and TR, the MC twins, less accurate because of fluid imbalance. But if it is tricuspid regurgitation or reverse A wave, it points to cardiac anomalies. Now, what about cell-free DNA, NIPT? Monozygotic pregnancies can be offered and the sensitivity is same as singleton. And 94.4% sensitivity you can have with NIPT. Whereas with dizygotic, each individual fetal fraction may differ, and if it is in low in the affected fetus, you can have a false negative results. So supposing you find a screen positive with NT or other markers, what you have to do is you may have to do an amniocentesis. And if you want to do an amniocentesis, you have to do both the sacs. And also it is indicated if there is discordancy in growth or discordant anomaly. The fetal loss rate is 0.3 to 2.2%, and always consider a late amniocentesis. Now, discordancy in CRL. What is discordant CRL means? It is 10% or more difference. You call it a discordant CRL, and that is a marker of selective growth restriction. It is not a predictive of TTTS. So, discordant CRL has to be kept in mind and to look for selective fetal growth restriction. But if you find a discordant NT alone, it is only 50% sensitive in predicting TTTS. But if you find a discordant DV and discordant NT, the relative risk is 21 for developing TTTS. And why it happens is because of overload. So this is a study in 2018 November. What they did was they studied NT more than 95 centile in one or both fetuses and TTTS, and CRL discordancy of more than 10% and TTTS. And what they found is that it is not currently possible to predict adverse outcome in monochorionic twins. So the take-home message is we have to be on the lookout for these complications developing if there is difference noted. Now the anomalies. Now structural anomalies, it is 2 to 3 times more, and it may show a Christmas cracker hypothesis. That means if you break a cracker, it may break out into multiple pieces. So you can have a short anomaly, you can have a big lethal anomaly or a non-lethal anomaly. And this could be because of gene imprinting, expression, hemodynamic factors. And what we want to do at this point of time is we have to see how we can make the normal twins survive and prevent a preterm birth. So as I said, the lethal problems can be anencephaly, bilateral renal agenesis. The non-lethal can be open neural tube defect, agenesis of corpus callosum, ventriculomegaly. Whatever be the anomaly, you can either go for a selective fetal reduction or an expectant management. But when you're doing an expectant management, you have to think that there is a consequence of single fetal demise, there is a chance of preterm labor and polyhydramnios. So the patient should be counseled accordingly. Now, if you want to do a selective termination, the best time is 18 to 20 weeks. And you choose a fetus which has got a worst outcome. You do it where there is discordant anomalies or an imminent death of one fetus. And what do? You do a cord ligature or a bipolar coagulation with 20 to 50 watt. And the survival of the other twin is 70 to 85%. So this is a picture showing cord occlusion under ultrasound guidance, local anesthesia, maternal sedation. Post-cautery, what do you see? You see that there's no color in the cord, there's bradycardia, and you've got to coagulate at 2 places. And as I said, you do it after 18 weeks, where the fetal loss will be 3%. If you do it before, you can lose the healthy fetus 41%. So the outcome will be better if you do it after 18 weeks, 70 to 80%. Now, if you find like a discordancy, you can have these 3 options. You can have a normal LICAR or an oligoamnios. Then you have to look for anomalies, selective fetal growth restriction, PRN. If it is normal and a poly, again anomalies, and close surveillance for any development of problems. But if you have a poly-oligo sequence, it is TTTS. And when do you call it oligoamnios, where the single deepest vertical pocket is less than 2. If the single vertical pocket in one sac is more than 8, you call it polyhydramnios. Now, as I said, we should look at the cord insertion. Here you see a central cord insertion. Here you see a velamentous cord insertion. And look at this study. In this study, if there is a velamentous cord insertion, there will be 30% birth discordance as compared to without birth discordance. Placental sharing again is more if there is a velamentous cord insertion. So you have to be on the lookout for cord insertion and mention if seen. So when you find such discordancy and everything is okay, you should not be assured. You should always look for complication. Now coming to specific conditions, you see these bubbles. Here you see TTTS, SFGR. That means these 2 are the main problems which develop in monochorionic twins. Others are less. So here you see growth discordancy can be seen in 14%. TTTS can be seen in 9%. Anomalies 10%. Placental vascular 26%. So these are the 2 things where we can do something about these fetuses. Now, why this discordancy? This occurs because of inadequate placental sharing. Very asymmetrical sharing associated with velamentous cord insertion, as I told you previously. And these vascular anastomotic patterns are because of shared cotyledons, increased net transfer to the other tin, and AAVV, they help to balance the blood flow. We find that these anastomoses have a protective effect on the smaller fetus. More blood is flowing to the smaller twin. In practice, large discordance with few anastomoses possible. Monochorionic twins with similar weight discordance may have varying outcomes, which is the rationale for selective FGR. So what do? We start scanning from 16 weeks, from 18 to 20 weeks, 2 weekly scan. At each scan, you do an effective fetal weight. You find out where the weight of the large twin minus weight of the small twin upon large twin into 100, and you find a discordancy of 20%. You find that there will be a perinatal risk. In addition, you should do the fetal Dopplers, umbilical artery, middle cerebral artery, PI, PSV, ductus venosus. And You can classify these IUGR babies into type 1, 2, 3. If it is type 1 with a normal Doppler, you give an expectant management. But if you find that there is absent reversal, or there is something known as intermittent absent or reversal, that means at one point of time you get an absent, one time you get reversal intermittently, there is chance for IUFD and neurological damage to the extent of 25 to 50%. And you have to discuss therapy option with the parents. So what do you do? If it's type 1, you carry along till 34, 36 weeks. Type 2, 3, you have to intervene by 32 weeks with steroids. Coming to TTTS, it is a problem of hemodynamic imbalance, volume overload to recipient, and cardiac evaluation is important in all these conditions. As I said, oligopoly is a must. Maximum vertical pool less than 2, more than 8 will help you in deciding whether it is TTTS. When you find that there is a sudden increase in the abdominal size or breathlessness, it could be a sign of TTTS. When you look at the MOMO twins, you find 100% AA-AV anastomosis. As compared to dichorionics, it is 79 and 93%. So again, when we get a TTTS, we look at the bladder, we look at the Doppler, and we stage. Stage 1 means Doppler, bladder donor visible, bladder donor not visible. Stage 2, stage 3, abnormal Doppler with A is recipient AV abnormal, B is donor, umbilical artery shows absent or reversal. Stage 4 is hydrops and stage 5 is death. But what you have to remember, it is a hemodynamic disturbance. It is not necessarily sequential. That means today if it was scanned, you find in stage 2, doesn't mean that next 2 weeks it becomes stage 3. It may become stage 5 in next 2 weeks. Or it may remain in stage 2 for maybe 6 to 8 weeks. So always we have to document and wait and see what is going to develop and bail out these pregnancies as the gestational age is achieved. Then I talked about cardiac assessment. As I said, there's increased cardiac load, there's AV regurgitation, chances for cardiomegaly, myocardial hypertrophy, dysfunction, reversal of DAV, RBOT obstruction, pulmonary stenosis, atresia. So how do you look at this? This is done by a fetal echo. In the fetal echo, you do something called myocardial performance index, MPI, also known as TEI index. This index will give you about global left ventricular function, which can be calculated by this formula of isovolumetric contraction time, isovolumetric relaxation time about ejection time. So then you can find out the global left ventricular function. And how will it help? Now, these various researchers have looked into all these aspects of the Doppler, of the heart, and come out with various scores. Out of this, the best score they say is CHOP score, that is Children's Hospital Philadelphia, where they are looking into the ventricular function, the various valves, and giving you a risk of mild, moderate, severe. And this correlates with Quintero staging. So by looking at the Doppler, we can stage the disease and stage the condition and decide upon management. And what do? Stage 1, you do an expectant management. Equipoise means at 20 point of time, you may need to take a decision. Stage 2 to 3, prior to 26 week, you may need a selective laser. But after 27, it is serial amnio reduction. And stage 4, it has to be individualized with laser or a selective feticide. Regarding amnio reduction, this is the most common procedure which postgraduates may also do. How much Riker to remove and why to remove? Because it reduces intraamniotic pressure, it improves placental perfusion, it will alleviate maternal discomfort. And how much? With 1 liter for every 10 centimeter AFI. So you have to reduce it to 25 centimeter. But you should remember that it should not remove more than 1 liter in 30 minutes and not more than 5 liters in each session. Any complication like PPRN, preterm labor, chorioamnionitis, abruption can occur. It is very effective in mild TTTS and later gestation age. Laser photocoagulation is sophisticated. We do use Nd:YAG laser, and at the end of the procedure, we also do an amnio reduction. Complications of this procedure is there But it is said that if there is a severe TTTS before 26 weeks, you should do a laser rather than amnioreduction. And after doing this procedure, you have to see whether the bladder is appearing within 24 to 48 hours, liquor is becoming normal. And if the procedure is done in well advanced centers, you have 75% survival for a single survivor and 50% for a double survivor. Coming to TAPS, that is twin anemia polycythemia sequence. It is seen in 1 in 20 monochorionic pregnancies. It usually occurs following fetoscopic laser, 13%, within 5 weeks. But in only 3%, you can have it spontaneously. There is no liker difference, only hemoglobin discrepancy. So how can you find out for any anemia? We know we depend on MCA-PSV. So you start looking at the MCA-PSV and you can stage it 1, 2, 3, 4. We look at the moms of the donor and the recipient. And depending on the stage, you can have a discrepancy in the hemoglobin postnatal. So you can start, so that is the importance of looking at MCA peak because there won't be any difference in liker measurements and you may be dealing with a case of TAPS. Then what do you do? Again, you do an expectant management. You can give intrauterine therapy if it is going for severe anemia, fetoscopic laser, IUT followed by fetoscopic laser or partial exchange for polycythemia. Then coming to TRAPS, it is usually happening because of AA anastomosis. It is seen in only 1%. And here you have a pump twin and a recipient twin. And the twin can have 4 morphological types. You can have an acardius, you can have acardius anceps, acardius amorphous, and ecormus. And this happens because of deoxygenated blood going into the donor twin, to the iliac artery. So the upper part of the body is not developed. And here the perinatal mortality rate is to the extent of 35 to 50%. And here there is 30 to 50% chance that the normal pump twin may die because of cardiac failure, hydrops, polyhydramnios. So how can you bail out these? By radio frequency. By radio frequency, you have a 90% survival for them. And how do you find out that there's an acardiac twin? When you do put in a Doppler, we'll find there is a mass, but there is no cardiac pulsation and there is color flow in that mass. And when you see at the direction of blood flow, you will find it flowing towards the acardiac twin instead of away from the acardiac twin. And when you look at the blood flow from caudal to cranial direction in the abdominal aorta, then if you find that the weight of the acardiac twin versus pump twin more than 70%, it's a poor prognostic factor. If there is hydrops, hydramnios, myelocephalus, it's a poor prognostic factor. Again, what do you do for them? You can just give serial amniocentesis, umbilical cord ligation, radio frequency, 90% survival. You can do laser, you can insert a thrombogenic coil in umbilical artery, or sometimes you may have to remove an acardiac twin. This is a study from Mediscan. They looked at 91 fetuses with TRAP sequence, and they did laser in 27, and they found that 80% live birth rate at 37 weeks with a relatively good birth rate. So you have laser as an effective strategy. Here again, 48 cases, 84% success rate. And when do you do it? You usually do it after 15 weeks. Higher the gestation age, more cycles are required. And this is a study which gives a very good live birth rate and a cord demise of only 12%. Cord entanglement is seen in MCMA twins, mostly by 30 to 34 weeks. You have to do a Doppler and find out these babies. Single fetal demise happens because of acute transfer of intravascular volume. So there can be a co-twin demise in 12 to 25, neurological sequelae in 18 to 25, anemia, cardiac failure. So for these, what you need is a close monitoring MRI 3 weeks post-demise. We know that if it happens in the first trimester, it does not impair development of the surviving twin. So the management depends at which age the demise has happened. If it is near to the term, it's better to terminate. If it is very early, you may have to take other methods. Now, there are risks beyond the fetus like hemorrhage, GDM, breakdown, hypertension, which are topic, but we know that these problems do develop and we have to be on the lookout for these problems. When do the deliver elective birth from 36 weeks?
आरो मला नाही माहिती, तुम्ही सांगा ना.
Monochorionic twin
ते मी नाही
continuing
बोलत, माझं
beyond
काम चाललंय
38
खरं.
weeks increases the risk of death. In MCMA twin, we should terminate around 32 weeks with steroids. Both twins should be monitored continuously. 30 to 40% of planned delivery may end up in CS. Always we have to keep a low threshold for CS. This is a study which says that there is no point in continuing pregnancy beyond 38 weeks. It is maybe associated with poor outcome. Low dose aspirin is indicated in twins if it's a first pregnancy, more than 40-year-old, more than 10 years since last pregnancy, BMI more than 35, family history of preeclampsia, and past history of preeclampsia. Preterm labor, we know that preterm labor, they have an increased risk. Cervical length is less predictive. Don't use untargeted steroids. 60% of twins deliver spontaneously by 37 weeks. What doesn't work is the bed rest, no routine progesterone, no role of cerclage. In the absence of other complications, CS has not shown to be improved, safer than vaginal birth for twins in multinational RCTs. So simplified approach for monochorionic twins is early diagnosis, rule out malformation, follow every 2 weeks by fetal Doppler. If suspicious for TTDS, do the treatment. If FGR, do a Doppler and decide on to the management. Uneventful 36-37 terminate. There are few slides on trials in twins or postgraduates. One is the Peristat trial, which was done in 2000-2004. They looked at 11 European countries to find out what is the preterm labor rate in these countries. And then they found in Scotland, it's 9%, in Austria it is 12%, 10% extreme premature. And then they said that clinicians in different countries have different approaches to multiple pregnancy. Then there's a Stop It trial where they wanted to prevent preterm labor in twins, and they gave vaginal progesterone gel for 247 and placebo. For 10 weeks they gave from 24 weeks, and they found that there's no significant effect in timing of delivery or IUD before 34 weeks or adverse outcome. Then Stop It 2 trial is going on at present. It is going on at Southeast Scotland. They're doing a TVS at 18 to 20 weeks with cervix less than 35 mm, and they're putting Arabian pessary to no pessary, and they plan to recruit 500 women, and they want to see what happens, whether they go for preterm labor and what is the neonatal outcome. And there's an Esprit trial. They said that threshold for significant growth discordance is defined according to adverse perinatal outcome. 18% for both DC and MC without TTDS and 15% with TTDS. And there's a Stoke trial which says that early pregnancy loss is more in monochorionic pregnancies. No difference in mortality after 24 weeks. It may be because we are able to detect and promptly treat complication in monochorionic and plan an early delivery. So friends, see, the technology has advanced. This lady at 75-year-old at Bengaluru is preparing this corn with solar. So we also have to use our Doppler judicially and plan a good outcome and give them twin happily. Thank you.